is Sweta, and I'm an PGY3 internal medicine resident at the University of Connecticut. I'm currently in the application process to pursue a rheumatology fellowship. I want to thank each and every one of you present here today, and I'm very grateful for this opportunity to present the study that we've been working on, titled Awareness and Attitudes Regarding Axial Spondyloarthritis Among Non-Rheumatology Providers. So the reason that we embarked on this study was the glaring discrepancy between population and diagnostic prevalence of axial spondyloarthritis and ankylosing spondylitis in the US. The delay between symptom onset and the diagnosis of ankylosing spondylitis has been estimated to be approximately 13 years. The population prevalence of axial spondyloarthritis is about 1.4% and ankylosing spondylitis is 0.55%. Showing us that axial spondyloarthritis is as common as rheumatoid arthritis, which is anywhere between 0.24 to 1%. But this is commonly underdiagnosed and missed, and this results in a significantly lower diagnostic prevalence, about 0.2% for axial spondyloarthritis and 0.1% for ankylosing spondylitis in clinical practice. The delayed and the misdiagnosis of axial spondyloarthritis in clinical practice may result from the lack of timely referral by non-rheumatologists. Primary care providers are the main source of referral for back pain patients to the rheumatologist. We hypothesize that this inadequate referrals stem from lack of knowledge, familiarity, and awareness of axial spondyloarthritis among non-rheumatology providers, who are usually the first line of assessors of patients with back pain. Hence, we aim to assess their knowledge, awareness, and attitudes about axial spondyloarthritis among primary care providers to identify the gaps in knowledge and devise strategies for referral. So this is a prospective study where a HIPAA-compliant, secure electronic survey designed by a study team of rheumatologists and primary care providers from Yale University and University of Connecticut was distributed via email to practicing primary care providers in select practices within Connecticut between February to June of 2021. A $10 Amazon gift card was provided on survey completion. The primary outcome of interest was to assess provider and practice demographics, familiarity with inflammatory back pain and axial spondyloarthritis associated features, axial spondyloarthritis terminology, as well as management and referral patterns for chronic back pain patients. The response data was analyzed in SPSS without any subject identifiers. So out of the 446 surveys we sent, 147 primary care providers completed the survey, giving us a response rate of 33%. Table 1 shows us the demographic data of the responders. 68% of them were MDs, 30% of them having a practice of greater than 20 years, a majority identified as female gender, and were part of a multi-specialty group. A majority of the providers saw patients saw 30 patients per week, and a majority of the providers felt that about 10 to 25% of their patients had chronic back pain and were younger than the age of 50. So the next few slides report the survey answers. So we divided the survey to assess 4 main domains of practices. The first one being the recognition and assessment for inflammatory back pain and axial spondyloarthritis associated features. 95% of the providers said that they were somewhat familiar with the term inflammatory back pain. 42% at least often assess for inflammatory back pain in patients with chronic back pain. 37%, however, are not comfortable making the diagnosis of inflammatory back pain. A majority of the providers do not assess for axial spondyloarthritis associated features like peripheral arthritis, psoriasis, inflammatory bowel disease, or a family history of spondyloarthritis. And greater than 75% do not look into features such as enthesitis or uveitis. The second domain was the familiarity with the change in terminology. Almost half of the providers were not familiar with the change in the nomenclature around the terms axial spondyloarthritis and ankylosing spondylitis. The third domain assessed the diagnostic ordering patterns. It was interesting to see that a majority of the providers never ordered HLA-B27 and C-reactive protein, but 35% did order ANA and rheumatoid factor when assessing young patients with chronic back pain. The imaging modality of choice was mainly X-ray of the lumbar spine and rarely or never MRI of the lumbar spine, X-ray of the sacroiliac joint, or MRI of the sacroiliac joint. The fourth domain assessed the referral patterns of their patients with chronic back pain. And as you can see, they were asked to rank the providers, the specialties in order in which the in which they would send the referrals, and rheumatology referral is ranked the lowest. To conclude, our study does suggest that there is a lack of knowledge and education regarding inflammatory back pain, spondyloarthritis features, and changed nomenclature of axial spondyloarthritis among primary care providers. Primary care providers are likely not appropriately evaluating chronic back pain patients for axial spondyloarthritis, and this likely contributes to the lack of rheumatology referral and the delay in diagnosis. This survey provides us a glimpse into the current real-world practice, thus offering us an opportunity for enhanced education and collaboration to help decrease the delay in diagnosis for axial spondyloarthritis patients and greatly improve their quality of life. Thank you.
Thank you, Sweta. That was very, very well presented. Interesting conclusions about the nomenclature and others. So I'd like to open it up. Anybody have questions?
A question for you. So very nice. So is the defect in medical school, residency, both? And how do we correct it if you were to consider this a quality improvement project? And I'm not sure things have changed. So when I was a resident at New York Hospital, there was no curriculum that involved outpatient medicine, especially in musculoskeletal disease. And I remember doing my first consult when I became a rheumatology fellow at HSS. Was a young woman in the emergency room at New York Hospital with polyarthritis. And I was clueless. I didn't know what questions to ask or how to examine her. So tough problem.
Yeah. So being a resident, I completely understand. I didn't know how to assess for joint pain or like what am I assessing. And the first time I learned that was when I did rheumatology outpatient rotation. So that was the reason that we embarked on this. So some of the things that we are devising at this point, like now we have the data, is giving educational talks, especially to primary care providers, either through the ACP and having them do a CME credit for it. And the second one is a little bit out of our reach, but we were thinking that if a patient has like chronic back pain, they're less than the age of 50, in their chart review, they have some features suggestive for axial spondyloarthritis or ankylosing spondylitis. We can even give them a best practice advisory, but this was not well received by any of the primary care providers who are having a best practice advisory fatigue at this point. So those were some of our two things that we're still like working on.
Sweta, I have another question for you. How do you think this? Just gotta hold it. How do you think this compares to if you sent out a very similar survey to pick up on rheumatoid arthritis patients?
That is a very interesting question. I feel like people are just more familiar with the term rheumatoid arthritis, and sometimes it might not be as low as axial spondyloarthritis or ankylosing spondylitis. I feel like their education might be a little bit better, but we could be wrong.
Dr. Lindsay here. Excellent. I think you didn't even get into the fact that the main reason that people are getting delayed diagnosis is that there's a higher prevalence of women in radiographic XPOM than what people expect. And so that would probably add another layer of reason why they're not getting referred. So the University of Toronto had published a paper early this year, and they did a collaborative study set up a center of excellence for spine. And so they would have a primary doctor just identify back pain in people under 50, and then if they did, they would refer them to this spine education center. And there they had some ADPs who had spent time studying back pain and learning about inflammatory back pain. And they would make the decision as to do HLV-27 or x-rays or whatever. And then the people that they considered moderate to high priority, they were rheumatologists. And by doing that, they were able to decrease the delay in diagnosis from 7 years to 2 years. So I think when Rich asks what we can do about it, that may be something that somebody's thought about, and that's one way would be to get some type of center of excellence where you train people and send the people there, and they really knew, because I don't know if you're ever going to Rich's point, really teach the primary care doctors. I don't really know that you really want them ordering MRIs and HLV-27s, because it'll be like the ANA. How many people do you see just exactly said they came in with back pain and they have ANA 1 to 80 and they referred to the rheumatology clinic. So I think that might be some way to look at it.
Okay.
Well,
That's an excellent point, and there are so many ANAs being sent for various reasons. This is a new one to me, but I agree. I'm not sure we also want MRIs and HLA-B27s on everyone. So are there any other questions for Sweta before we move on? Okay, thank you very much.
Thank you so much.
So our next presentation will be Gretel de Souza,